Good morning, good afternoon, good evening, everyone, to our global audience who are joining us from around the world. Welcome to the 6th World Sepsis Congress. My name is Abdulelah Alhawsawi. I'm going to be your moderator today. It is my pleasure to moderate this session, which is titled Challenges and Innovations in Pediatric Sepsis. Sepsis remains one of the leading causes of preventable death globally. And when it comes to children, the challenge becomes even more critical. Pediatric sepsis is often difficult to recognize early, progresses rapidly, and continues to expose gaps in awareness, diagnostics, and timely intervention across healthcare systems. So we have an amazing panel today to go over this very important topic. I'm going to be introducing them one by one. And just to remind everyone that we will have around 10 minutes of speech per the panelist. And then we will have 2 to 3 questions, depending on the time, for each panelist. Before we start, I would like to extend our sincere thanks to the organizers of the World Sepsis Congress, as well as our sponsors for making this global exchange of knowledge possible. So without further ado, I want to introduce Dr. Nelson Sanchez-Pinto, who's a pediatric critical care physician, data science researcher, and a clinical informatician. He joins us from the Children's Hospital from the Northwestern University and Ann Robert Lurie Children's Hospital of Chicago. Nelson, the floor is yours.
Thank you so much. Thank you for the invitation to speak and for the Global Sepsis Alliance for inviting me. It's a pleasure to talk about this topic today, digital solutions for pediatric sepsis. It's a short talk, so it's going to be pretty high level. But hopefully if there's questions, we can have some discussion and some follow-ups. I don't have any disclosures, financial disclosures. I do have funding from the NIH for the work that I do in this space, and some of the work that I'm presenting today has been funded by the NIH. The big disclosure is that most of the presentation today is anchored on this paper that we published in 2024 on digital solutions for pediatric sepsis, published in Lancet Digital Health. For those who are interested in this topic, I invite you to read this paper, and we'll use the framework for this. And the other anchoring piece disclosure is that I'm basing a lot of my discussion around the compliance with the Surviving Sepsis Campaign guidelines from the Society of Critical Care Medicine, which sort of serves as a good grounding approach to how we manage sepsis and how we develop digital solutions to manage sepsis. So the big framework that I want to present is the idea that digital solutions for sepsis should be based in the 3 phases of care of patients with sepsis. We can think of sepsis as a journey that patients go through the different steps, all the way from presentation, when they may be one of many patients that present with non-specific symptoms like fever or not feeling well, and it's unclear if they have sepsis or not. And so that's the initial phase of presentation, having to screen, and then moving to a phase of diagnosis. Once the patient is diagnosed, then there's additional characterization of the patient's phenotype of how they're responding, what organ dysfunctions they may have. And that phase is when we try to target therapies to the types of organ dysfunction that the patient has, or the type of immune dysregulation that they may have, or whatnot. Hopefully, most of the patients survive their journey, and there's their episodes of sepsis and septic shock, and eventually get discharged. And of the patients who go back to their lives and outside of the hospital, there's going to be a subset that we know is going to be higher risk for having worse outcomes long term, and those are the patients that we want to target with more specific follow-up and case management to improve their long term outcomes, particularly in children who can have lifelong sequelae from an episode of sepsis or septic shock. So if we think of this journey in these 5 steps, we can really divide the phases of care in sepsis into the pre-diagnostic phase, the acute management phase, and the post-discharge phase. And in fact, the Surviving Sepsis Campaign guidelines have recommendations for each one of these blocks of care, with the bulk of the recommendations being in the acute management phase, which makes sense. But now we are seeing the emergence of recommendations around the post-discharge phase and focus on long-term monitoring and prognostication, which I think is it's a great advancement of the most recent guidelines from 2026 in children. So using this framework, I'm going to present now some examples that we've worked in our hospital and we've developed and published on for digital solutions at each one of these different steps in the journey for the patients. Starting with the presentation phase, which a big focus of digital solutions in this space has been the development of early prediction tools, of digital screening tools that can help us identify amongst undifferentiated group of patients which ones are the ones with the highest likelihood of developing sepsis. One of the recommendations from the Surviving Sepsis Campaign guidelines is to hospitals to implement performance improvement programs that include this early identification of patients. And this is a diagram from the campaign that basically alludes to the fact that identifying probable sepsis or suspected septic shock even before the diagnosis is definitive is important because this patient should be started on empirical therapy relatively quickly, even if it's not confirmed that the patient has sepsis at that point. If the suspicion is high enough, they should be preemptively, empirically treated, maximum 3 hours if it's probable sepsis, and maximum within an hour if it's suspected septic shock. And so following this type of recommendation and this idea of early identification, we developed a prediction model in our hospital a few years ago because we had recognized that we had an opportunity to improve the timeliness at which we identified patients who were developing sepsis amongst those who were hospitalized for other reasons, and the ability to improve the time to antibiotic administration and resuscitation in those patients. So we developed a prediction model using electronic data from the electronic health record from our patients, using a machine learning approach to predict sepsis in a retrospective population of about 40,000 patients. And then we tested this prospectively for a year, and it performed really well. So we then implemented it live in our electronic health record in a fashion that when you open the electronic health record and you have a list of patients, you can see what the sepsis screening score is. And patients are divided into 3 different tiers, with the top tier being the high-risk group, in which an alert is fired when the patients reach that level. And this is recommended. The recommendation of this alert is to have a bedside evaluation of the patient with the bedside nurse, the charge nurse from that unit, as well as the medical team, to discuss whether the patient that they have in front of them truly looks like they're developing sepsis, or maybe the symptoms are explained by some other reason. And in that discussion, oftentimes will lead to these patients starting empirical therapy. What we've noticed in the last 2 years, 3 years since we implemented this, is that we've had a significant decrease in transfers from the regular hospital wards to the ICU for septic shock, about a 46% decrease in that level. I want to mention, though, that even though the focus of this work initially was very much on the prediction model and how we presented this data to the clinicians, that it was very much focused on the technology, what we really learned through this process is that where the magic happened, where the effectiveness of this happened, was really on the human aspect, on really focusing on the implementation and the human workflows. The next sort of phase step of the journey for patients is the diagnosis, and this is an important step for both confirming those who have a diagnosis of sepsis so that we can follow best acute management guidelines for those patients who indeed meet the criteria. So those who had suspected sepsis that don't meet criteria can be then treated with less aggressively. And then also in this phase, we have an opportunity to do some risk stratification. The new recommendations include this new recommendation for measuring blood lactate, which is in part to be able to do this risk stratification early in the diagnosis of sepsis. And conveniently, for both the diagnosis and risk stratification, we have the new Phoenix criteria for sepsis in children that we published in 2024. Here's the small table. You probably can't see the details here, but this is the Phoenix sepsis score that can score every single patient with infection with a score from 0 to 13, and that can be used to establish the diagnosis of sepsis in those patients with suspected infection or confirmed infection that have 2 or more points of the sepsis score. But on top of that, the convenient piece of the Phoenix sepsis score is that it actually also stratifies patients across a full range of risk. Here in these 2 figures, you can see the top one is in data from high resource countries. The bottom one is data from low resource countries. The x-axis is the score as it goes up, and the y-axis is the mortality. And you can see, which is each increase in the score, we have a stepwise increase in risk of mortality. So you can use the Phoenix sepsis score to classify your patients with sepsis into, low risk patients, high risk patients, and that can help with prognostication, can help with maybe with management, with triaging this patient, with transfer to a higher level of care. We now have implemented the Phoenix score in different ways. So we developed a mobile app that can be used in smartphones in low and medium resource settings, and that's freely available. We've also developed automatic calculations of the Phoenix sepsis score in the electronic health record in our hospital. This is a screenshot from my hospital, but we have other implementations in other hospitals that we've been working with. This is obviously more for high and medium resource settings where there's electronic health records, but this is a digital solution to implement this new criteria that can help us diagnose and stratify patients. The next phase is this phenotyping and targeted therapy, where the focus really is on real time treatment recommendations to target best practices to the patients that are going to benefit from those interventions. One of these many recommendations out of the 50 in the acute management part of the Surviving Sepsis Campaign is this idea of preventing excessive fluid administration and considering active fluid removal in case of fluid overload. To comply with this recommendation, a few years ago, we developed a dashboard, bedside dashboard. So it's a digital dashboard that sits outside the patient's room in our ICU, where we track a series of metrics, of quality metrics. But one of the important ones is this fluid overload percentage metric that we are able to present to the teams on a daily basis. It updates continuously, and it can help the team determine if the patient has fluid overload and they may need dialysis, or they may need more aggressive diuresis or more restriction of the fluid intake. And this has resulted in a significant decrease in the number of patients with fluid overload in our ICU. And this is again another digital solution that can help us with this sort of more targeted therapies in our patients with sepsis. Finally, the last phase is the discharge. This patients when they're ready to go home, and the focus here is on prognostication to determine which patients who survive sepsis are at higher risk for having long-term problems. And for those who have higher risk, then have a more targeted and specific follow-up that can identify these patients as soon as they start deviating from the expected recovery, and potentially are in need for additional resources to improve their outcomes. One of the new recommendations in the Surviving Sepsis Campaign guidelines for children is that for children who survive sepsis or septic shock, it's important to assess risk factors for post-sepsis morbidity. In this space, we've developed a tool that we haven't actually, this is the only one that we haven't really implemented clinically yet, but we're looking to do so, which is using heart rate variability. So the beat-to-beat changes in your heart rate can change with disease and recover during recovery. So what we did is we looked at our patients with septic shock who survived their hospitalization, and we looked at their heart rate variability change towards the end of their care before they left the hospital. And we were able to predict which patients were more likely to be readmitted based on the trajectory of recovery of their heart rate variability. The nice thing about the heart rate variability is that nowadays this is available in the smartwatches, so people can, you can imagine survivors of sepsis going home with a smartwatch and an algorithm embedded in the smartwatch that can be tracking the heart rate variability and alert us when the recovery of the heart rate variability is not as expected in that patient, alerting us that we perhaps need to bring him back into a clinic space and assess what other needs they may have. The take-home, this is the last slide. The take-home message, though, as I was mentioning earlier when I talked about the sepsis prediction model that we implemented in our hospital, is that success in digital solution implementation is more about the people than the technology. A lot of the focus on digital solutions is on building technology that's fancy and potentially has a lot of uses, but really the magic happens when we include the humans. There's this saying from Sun Tzu, from the Art of War, that tactics without strategy is the noise before defeat. And in this case, the tactics are the digital tools. So if we focus only on building tactics, which are these digital tools, this alert systems, prediction models, dashboards, whatever, and forget about the strategy, which is really about the people and their human workflows and their clinical decision making, how people interact with this information. If we don't focus on building strategy to implement these digital tools, then the digital tools are not going to be used optimally. So really the magic comes in how we integrate this to the human component of patient care. So thank you very much, and hopefully you have maybe time for some questions.
Thank you very much, Nelson, and fantastic presentation. We don't have time for one question. There was a question about whether what you presented was a prediction tool or an early recognition tool, and maybe just to add to that, given the fact that we have a global audience, so we have people from high-income countries, but also we have people from low and middle-income countries. How can you also make that take-home message something practical that can be customized, at whatever settings?
Yeah, absolutely. I think so. In the first question, this was a prediction model, so we trained it to predict the occurrence of sepsis, in the next 12 hours. So it's not a screening tool, but rather a prediction that in the near future you're very likely to develop sepsis. So it's truly a prediction model, a supervised machine learning model. And the second question, I think this is a phenomenal question. I think that the cost of some of the technologies that we're talking about is rapidly falling, right? Like everybody has a smartphone nowadays. Not everybody, but around the world is very, very prominent. And some of the other technology that we've been working with things like wearable sensors, so like stickers that can sense your heart rate, your respiratory rate, your capture your blood pressure in wireless settings, and those can be connected directly to a cell phone. They can be connected to an iPad. So you don't need a fancy monitoring system. You just need a sticker and a cell phone, and you can already have basically a monitoring system with beat to beat vital signs, for example. And we've seen some work in Bangladesh, in Dhaka. They're doing some piloting of some of these wearable sensor technology to predict sepsis and do early warning. So in a low resource setting, this has been being trialed. There's some work in Uganda using the Cybele wearable technology in babies, also showing a lot of promise there in a low resource setting. So I think the technology cost is coming down, the accessibility is going up. And I think the magic, again, as I said, is when the humans are involved. So in any setting around the world, as this technology becomes available, I think there needs to be a really thoughtful sit down of the clinicians and the frontline providers to really think, how do we integrate this technology into our workflow? Or how do we change our workflows in a way that optimize the use of this technology? But you don't have to be a tech expert. You don't have to be a digital health professional to be in that table to make those decisions. You just need to be a frontline provider, a person who understands the care in your context, and you're going to bring a lot of value to how that digital tools are brought to the bedside. So don't be scared of the technology. I invite you to be present, to raise your hand, say, hey, this is not going to work because of this, or this will work better if we do that. That's where the magic really happens.
Brilliant. Thank you very much. And as you speak, the number of audience and people coming in is coming up. So I'm just going to say that stay tuned for, we just heard a fantastic presentation. So stay tuned for 5 more great presentations. So it is my honor now to introduce the next speaker, Dr. Suchitra Ranjit, who's an pediatric intensivist who's trained in Melbourne and Sydney, and she was the first trained intensivist to set up several pediatric ICUs in Chennai, South India. So, Dr. Suchitra, the floor is yours.
Thank you. So, I just lost my... thanks very much for the kind invite. And I think there's a lot of commonality between my talk and Nelson's. I'm just going to share, maybe Nelson could stop sharing? Has he stopped?
Yeah, I stopped
Yeah.
sharing.
Thank you. So mine's good. Yeah. So I'm going to be talking on both the early recognition, basically about the early management of pediatric septic shock. And given the absence of large-scale clinical trials, I'm going to be talking about our published data and observations. So how we manage early when in differently resourced, lesser resource settings. And this is the outline. I'm going to go very quickly over the first few and a little more in detail midway. So basically, we need to, everybody knows that improving the social determinants of health will decrease the burden, and that's important. That's important when you have less beds and less personnel. And of course, merging emergency and critical care services rather than having silos. So you can, again, have, if there are less people, less technology, less equipment, you can make it work for a larger burden of patients. So although the Surviving Sepsis campaign this year said that sepsis screening was a lesser level of recommendation, a screening tool that requires minimal training and resources may work. And once you pick up the patient, once a child with sepsis is picked up, this is what I think can make a difference, improve the success rate by improving the logistics. So the first hour bundle of 5, there was a nice article from Bolivia, and they described a sepsis adherence, which included, surprisingly, not just fluids and inotrope, not just fluids and oxygen and blood cultures and antibiotics, but also early vasopressor administration. And they could demonstrate that this led to lower mortality and better outcomes. So in our hospital too, we do the sepsis 6, which includes all that was described in the study, but also a physician review and if the child is in shock, a POCUS, a bedside ultrasound is also done. All of these are done within an hour. It seems quite challenging, but we make it easy by having a shock trolley. So everything that you need is there, and there's a portable ultrasound machine. And one of us, either the ER consultant or the ICU consultant, comes down very quickly. And within an hour, we pretty much know how the hemodynamics are, how much fluids they need, whether their heart is functioning well or not, etc. So this was our most recent small pilot trial comparing epinephrine and norepinephrine. And we had 100% compliance with all 6 elements within the first hour. So we just need to make it easier for people to achieve compliance by keeping things all in one place, so nobody's running around and making phone calls and raising indents, etc. So about fluids, it's a huge topic in itself. We know that while fluids improve perfusion in diarrhea, in septic shock, the response of cardiac output, so 3 parameters that we check before and after fluids, the cardiac output, whether it improved, the filling parameters or respiratory deterioration, and the blood pressure. We expect fluids to improve cardiac output, improve the blood pressure without worsening respiratory parameters. But all of these 3 can be very unpredictable. And so we need to be really thoughtful about fluids, not give bolus after bolus without assessing the patient. There's a lot of bedside assessment that is required. So let's consider the physiology. We know that compared to diarrhea, where there's pure diarrhea, vomiting, or pure fluid loss, a child with septic shock has a greater degree of relative hypovolemia where fluids are redistributed. So there's a little bit of capillary leak, but mainly the venous capacitus vessels are dilated. So the fluids are redistributed and not reaching the heart and partaking of the circulation. So what is the most physiological way to improve venous return and cardiac output? Is it when there's relative hypovolemia? So both of these will work. So both of these, meaning large volume fluids or a small dose vasoactive, both might work. But large volume fluids, we've shown that, I mean, everybody who's given large volume fluids knows that they then need much more of ICU technology, such as ventilation, rescue inotropes, dialysis, and maybe longer ICU stays. So while aggressive fluid loading can keep the ICU rather busy for the next few days, and this approach may be a problem. And especially if there's profound hypotension, regardless of the resource availability, the surviving sepsis suggests 40 ml per kg fluids. But when you look at the physiology, maybe even when a child is hypotensive, the main pathology, the physiology is vasoplegia. And earlier vasoactive can stabilize the map and circulation maybe more efficiently than large volume fluids, which can be transient because of the disrupted glycocalyx in sepsis. So a preferred strategy might be low volume vasoactive, which can improve the cardiac output even without a drop of fluid, and the improvements may be sustained. And the need for ICU resources are much less. So now that we if you agree that vasoactive early is a good idea, we need to decide which is a good first-line vasoactive. Ours was a very small study suggesting norepinephrine, but over the last 25 years, we've it sounds blasphemous almost to say that pediatric septic shock is virtually the same as has similar pathophysiology as adult septic shock. And you can, especially after giving the first bolus of fluid, you can see what happens to the blood pressure. The diastolic is lower and the pulse pressure widens. So maybe low dose norepinephrine and septic shock may be better together. And this is what we have consistently shown in our reports over the last few years. And if you're giving norepinephrine, when do we give inotrope? And the key is perfusion. We should not be treating the echo picture, even if the heart is poorly contractile. If the child is perfusing well, we don't need to add on an inotrope. And if the perfusion is impaired, look at the map and decide on which agent that needs to be added. If the map is low, then adding epinephrine may be a good idea. So what about intubation and ventilation? Just like fluids, some life-saving interventions may be life-threatening. And we know that the whole switching from spontaneous breathing to positive pressure ventilation can worsen shock with a lot of other downsides. And we need to individualize rather than intubation being automatic. If you are intubating, it's a good idea to use a high-risk intubation bundle to decrease complications such as cardiac arrest and severe hypotension. If the shock is unresolved, remember source control. Look very aggressively for source control, which is the best antibiotic. And in cases of refractory shock, sometimes it's the caregiver that is causing the problem. And there's increasing reports, including our own, of catecholamine-induced myocardial dysfunction. Dialing down the catecholamines improved perfusion. And yes, so I think that was my last slide. catecholamines can also cause dynamic left ventricular outflow tract obstruction, worsen shock. So it's a good idea to accept lower blood pressures until David Inwell's study is out. Generally, test whether a child can accept lower blood pressures, see how the urine output is, see how the mentation is, how the pulses are, and maybe go for lower blood pressures if the perfusion parameters are acceptable. And that's, I'm done. That's my last slide. Thank you for the opportunity.
Thank you very much, Dr. Suchitra. So if there is one kind of take-home message that you would like the audience, to leave the audience with, what would that be? And if I'm a a pediatric emergency physician in a small hospital, how what you presented, how can I practically take that and implement it to the betterment of my patients?
So that's a brilliant question, and it's quite a challenging one. So what I'm trying to say is the first hour bundle remains the same, right? So you're given the sepsis 6, early recognition, antibiotic cultures, oxygen, and the first bolus of fluid. And maybe add on a vasoactive, which I suggest a low dose, 0.5 to 0.1, a low dose vasoactive such as norepinephrine may do the job. The response to fluid and norepinephrine is fantastic, because if they get better, that's fine. But if they don't, it's quite clear whether they need more fluid or maybe need an inotrope if those bounding pulses have suddenly disappeared, right? If the child is more tachycardic after fluid and norepinephrine. You don't need an echocardiography. I mean, you don't need somebody to come and do it. You know that an inotrope is required, right? The patients who are tolerating the norepinephrine, most of them are in vasoplegic shock. Patients who are tolerating the low dose norepinephrine, you can bump the dose up or even add vasopressin, right? So it's the clinical exam. The previous speaker told us that the people at the bedside are those that are doing the magic. And I fully agree with it. You need frequent clinical examination. Listen to the patient, touch the patient, and you can figure out what needs to be done.
Great. So as they always, taught us in medical school, treat the patients, not the numbers.
Right.
Brilliant. Again, another fantastic presentation. Thank you very much, Dr. Suchitra. So moving on to another speaker. Basically, we have started with Chicago and then moved to India, and now we go to Africa. So it is my pleasure to introduce Dr. John Appiah. He's a fellow of the West Africa College of Physicians, the Ghana College of Physicians and Surgeons, and College of Medicine, South Africa. He is the head of the unit and a senior specialist and pediatric intensivist at the Komfo Anok Teaching Hospital in Kumasi, Ghana. Dr. Appiah, the floor is yours.
Yeah, thank you very much, Abdulelah. And I'm grateful to the organizers for the invitation. I think both Nelson and Professor Suchitra actually had made significant contribution to my talk, and hopefully that's going to make my discussion a bit easier. I have no financial dealings to declare, except that some of the work that we have done has been supported by funding from some universities in US. Again, we have heard this about what sepsis is in terms of time. I want to skip that. But the fact that why should we take sepsis seriously, especially in our part of the work? Since 2016, when we started working, looking at our numbers, and then realizing sepsis is becoming more of a problem. At this point in time, almost 80% of patients who we admitted with multiple organ dysfunction were all dying, both in some places. But this data came from our hospital. We decided to take a journey to understand what is going on and then actually look at where we are. This talk necessarily is for low middle income countries, but I'm situating it in work that we have done in our geographical area as Ashanti region in Ghana. We are excited when we get excited when the guideline development guideline is put out, but they are I want to touch briefly on the processes that guideline developers go through and then put that out. It's a rigorous process that involves defining a question, eventually put out a panel to look through and come out with their recommendation. The recommendation usually is based on what the preferences and the values of users are going to use. In terms of preferences, we look at patient interest, we look at the implementation decisions, contribution that needs to go into that, and choices that the clinicians will have to make on behalf of patients when managing them. Having said that, we present guidelines in the form of bundles to make it easier to implement it. And then we have known that for some time that bundles actually is very relevant and then improves patient outcomes from the work we do. And now zoning into the most recent guidelines, which is going to put out for the pediatric aspect, we are looking at recommendation for bundle care in terms of bundles. Performance improvement. I think Nelson spoke about that a little bit. I don't want to waste more time on that. The next one is antimicrobial bundles and then rehabilitation bundles. All these and including post sepsis follow-up. All these are very important when you put it out there, but when it comes to implementing it, we've had the guidelines for some time now, but in many resource-limited settings, rather mortality is not improving. The question is, why are we not seeing mortality improving as a result of getting quality evidence, recommendations based on current evidence? Why are these happening? In our setting, for instance, almost 10% of our admissions were patients who come in with sepsis. And then out of that, almost 80% of those with multiple organ dysfunction will die. We have the guidelines, all right, but what is happening, why things are not falling in place? All right. We decided to look at hindrances to implementation as part of improving patient care and patient outcome. And then looking at that, after doing going through several processes using fishbone analysis to work with our own staff, the nurses, the doctors, allied health workers, some of the things that we listed, which we wanted to study a bit further, was resource limitation and then systemic barriers that actually exist. Through that, the study that we conducted actually was beyond the sepsis bundles, contextualizing pediatric care in resource-limited setting. It's available for anyone who is interested to read more about that, but because of time's sake, just briefly, we did this study with the methods. It was more of a needs assessment process where we use situational analysis. And then the two key framework that we used was the CFR, Consolidated Framework for Interventional Research. But we also situated that in the context of the Nigerian model to understand where we are, where things are not working right. So in terms of these, we're looking at resources, communication, and then team dynamics, the funding available, patient needs, and then all those. We did this through environmental scanning. in two different hospitals. One is a secondary hospital and the other is a tertiary hospital. In Ghana Secondary Hospital, more or less, they are the first point of contact for severely ill patients. So there are clinics, we have clinics, primary care facilities where basically non-acute, acute, non-severe, acutely ill patients are. But when you're acutely ill, severely ill, you need admission, patients are referred to the district hospitals for care and management. And this is where most of our patients with sepsis actually manage. And we look at the resources that they have within these two areas. Presbyterian Hospital Agogo is a district hospital, and then Komfo-Anokye Teaching Hospital is a district hospital. And we look at it with the window of staffing, with the window of diagnostic equipment available, with the window of referral, with the window of beds available to manage patients. And then additionally, aside the clinician managing the patients, other resources, when a patient becomes acutely more require escalation of care, how the care is going to be received. Basically, the results show that we have variable resources to manage patients who are very ill. In the region I'm talking about, Ashanti region I'm talking about, the only referral center serving over 5 million people was the Komfo-Anokye Teaching Hospital. Presbyterian Hospital Agogo is one among several secondary district hospitals that actually refer patients. Patients who require acute, high acuity care, usually at Presbyterian Hospital have to refer to Komfo-Anokye Teaching Hospital because they do not have the resources. Interestingly, looking at this through that window, we looked at staffing again, power supply, which all these variables were present in almost all these facilities, but in varied availability. Staffing, for instance, Komfo-Anokye were quite resourced with a number of subspecialists to manage cases. Power supply, backup generator, resuscitation to hear clear variation in availability of resuscitation, whilst Agogo had basic ambu bag, face mask, oxygen for resuscitation. They didn't have anything further to maintain airway, patient monitoring too. So these were all, we thought these actually, even though we had bundles out there to work with, the resources for them to implement actually were not really strong enough. We also contextualized between the two facilities what these resources, in terms of the resources available. While we scanned the whole hospital, we realized that Agogo, for instance, had a backup with an ongoing robust research center. However, because of how implementation of certain programs are, we tend to have vertical implementation, and resources made available for those research groups were actually being used for only malaria research, for instance, specifically. And again, going down, I think the fact that, what we identified is that vertical programs usually less strengthen health resource, health systems, and we need to look at how to go about it, how to improve that utilization of that to benefit the whole patient population that we see. Basically, in Ashanti region, the availability of medication matched what WHO emergency medicines list actually provides, so that were available. However, WHO essential medication list. However, availability depends on whether the hospital has stock. In some cases, they are not available, stock out. So the patients will have to go out and then go and get the medications. Again, we talk about identification of organisms that actually will help us understand our antibiogram and then prescribe the best treatment. What you notice is that they have one antibiotic, and patient, whether they are responding or not responding, they throughout the patient's course, throughout the patient's course of stay in the hospital, the same antibiotics being used. And if we keep on changing antibiotics blindly without the necessary tools and the resources in Agogo and in sometimes at Komfanochi Teaching Hospital. I've mentioned the airway and then respiratory support, also variability. Bed space are really a problem in Ghana right now. We have what we refer to as no bed syndrome in many referral centers. And that's actually, it's a major problem in Ghana. How do we improve that? And without appropriate, adequate bed spacing, how do you manage patients with multiple organ dysfunction? And these are contributing to worse outcome for our patients. And I guess I touched on this briefly in terms of the resources available, research resources available. Funding has been in the form of, for a while now, Ghana's funding system for healthcare has been based on the colonial type of funding where resources are actually handed down from the top. The hospital managing cases barely have ability to make input until recently, where the government, actually the Ministry of Health, the minister actually put in regulation asking that hospitals maintain 10% of their internally generated funds to service their equipment and then even procure new equipment. So we're dependent on someone somewhere procuring equipment for you to be used. Sometimes they procure things that you might not even need. The other thing, which is the National Health Insurance, is actually has been very helpful for many, but still not able to, does not cover everything that sepsis care actually gives. And as a result of that, one of our earlier research that we did show that many of our patients, delay of care, one of the reasons was the fact that the fear of the patient, the cost that they need to go through. In conclusion, I think when we are thinking about guideline implementation, there's the need for us all to think about how we can address the structural hindrances or the limitations, and then look at the processes and the inefficiencies that are characterized by that, and that they are potential for direct impact on our patient because they have direct impact on our patient's outcome. Without that, we can put out several bundles, several guidelines, recommendations. Outcomes might still be the same in resource-limited settings. Thank you, and over from me. This is my last slide.
Thank you very much, Dr. Appiah. Great, information in terms of even, the comparison between the two hospitals, the secondary hospital and the tertiary hospital. Did I get what you said, correctly, that even though that you have good implementation of the bundles, the mortality rate is not coming down? If you can just speak to that in the comparison between the two hospitals, is that the case, or did I just miss what you mentioned?
Yeah, thank you very much. So we have the bundles. Most of this, or a number of the staff, are aware of the bundles available to use. However, there are hindrances to its implementation at both sites, from the district hospital and then the secondary hospital and then the tertiary hospital. And that was the message I'm taking across. So across these two different levels of care, we still have hindrances all over. They might not be the same in terms of what is happening at different levels. These two are more or less publicly funded hospitals, and more than 40% of our healthcare system, actually more than 60%, actually funded by the public system. And we need to understand these hindrances to be able to do that. So not that it's being holistically, one is not holistically implemented due to the limitations, the hindrances that we have identified. Thank you, Oliver. Yeah.
And can you just speak quickly to the appropriateness of the use of antibiotics where, with the bacteriogram? Like, do you have a bacteriogram that is present in both hospitals?
Yes, yes and no. It's present. The Agogo Hospital, for instance, the district hospital has a research. As I said, they have a robust research facility. But in terms of using the results they are getting to translate into antibiotic diagram for their facilities is non-existent. At the teaching hospital, the tertiary hospital, it's available, but there is lack of communication, inadequate communication. There is we have started working on that, but inadequate communication, looking at the global picture within the hospital, what antibiotics work for specific patients or what antibiotics do not work, and when to change the antibiotics. These are all challenges, gaps in the system on how to implement the antibiotic that we have. So the resources more or less are available, but in terms of teamwork communication to utilize these, it's a problem. It's an issue. Thank you.
Thank you so much. So 3 great presentations, and you have witnessed, and 3 more great ones to go. So we flew from Chicago to India, and then to Ghana. Now we're coming back to the U.S., but to the West Coast. It is my privilege to introduce the next speaker, Dr. Teresa Kortz, who's an associate professor of clinical pediatrics and critical care medicine. She's the director of the Institute for Global Health Science Affiliate Program and the director of the Pediatric Global Health Scholars Pathway at the University of California, San Francisco. And I believe she's going to talk to us about maybe, the last question that I talked about, the pathogen. So Teresa, the floor is yours.
Great. Thank you so much. Yeah, and thank you also for having me. So I'm pleased to present today identifying the pathogens in pediatric sepsis across the world. And this will be work that we've done both at University of California, San Francisco, as well as in Tanzania. I have no financial disclosures. So as we know, sepsis is a severe global problem. 1 in every 3 deaths globally are due to sepsis. And we also know that it disproportionately affects populations in resource-constrained settings, as well as children. We recently published the Sepsis Chain of Survival, which is a framework for improving sepsis outcomes, and it starts with sepsis awareness and prevention, early recognition, continuous source control, appropriate fluids, oxygen and antibiotics, critical and intensive care without walls, and post-sepsis care. And we know that early targeted therapy decreases mortality, and that appropriate antibiotics, to your point, treat the source and decrease the risk of antimicrobial resistance. So really, pathogen identification is critical for the sepsis chain of survival. A recently published study in JAMA was a U.S. national surveillance study of more than 51,000 pediatric sepsis cases, and they found that blood cultures were only positive in 16% of sepsis encounters. In 2023, a separate U.S. cohort study of children with severe sepsis and septic shock reported that 41% of sepsis cases were culture positive. So that means that 59% were culture negative. So still, the sepsis pathogen eludes us. And too often, we're treating sepsis blindly. And this is actually made quite a bit worse by the global diagnostic gap. The Lancet Commission on Diagnostics estimated that 47% of the global population has little to no access to diagnostics. And diagnostics can be used for both treatment as well as population-level surveillance. It has direct health and economic outcomes, and it's part of the larger universal health coverage goal. So because of the global diagnostic gap, the pathogen is even more rarely identified in resource-constrained settings. So this was a large systematic review and meta-analysis. It included prospective studies that assessed fever etiology using lab-based diagnostic criteria, and included more than 54,000 hospitalized adults and children in low and middle-income countries. What they found was that 80% of cases had no pathogen identified. And interestingly, antimicrobial use before admission was quite common, in some studies up to 48%. So our current gold standard for diagnosing bacterial infections is microbial culture. And even though it's our gold standard, there's a lot of limitations with microbial culture. It requires infrastructure as well as expertise. It's quite slow to get results. It's relatively low sensitivity in young children because of the blood volume that's cultured. And as we know, prior antibiotic exposure increases the likelihood of false negative results, and prior antibiotics is quite common in resource-constrained settings. Some fastidious bacterial pathogens are not easily cultured, and things like viruses, fungi, and parasites are very frequently or always missed. So overall, culture-negative sepsis is a common phenomenon and one that, as clinicians, we've all faced quite often. So one innovation for sepsis diagnosis was the development of rapid diagnostic tests. And this was great because it brought faster answers to the bedside. And the turnaround time can be minutes, which improves time to targeted therapy. And it does not require extensive laboratory infrastructure. It's also easy to use by design, so there's no need for specialized training. So we did a study to determine the sepsis etiology in Tanzanian children, and we leveraged the expertise at Muhimbili University of Health and Allied Sciences in Dar es Salaam, as well as UCSF and the Chan Zuckerberg Biohub. And we included children outside of the neonatal period up to 14 years. And all participants received a blood culture, malaria, and HIV rapid diagnostic test. And what we found was that malaria positivity was 6% in this cohort. Microbial culture was positive in 5%. And overall, when we combined all of the locally available diagnostics, only 12% of children had a definitive pathogen detected. So the rapid diagnostic tests are great. They're useful for sure, but there are limitations. So they are usually specific to a pathogen. So you have to have an a priori suspicion for a particular pathogen in order to trigger testing. There's also limited sensitivity if the pathogen load is low. And RDTs rely on visual user-dependent interpretation, so that can be subjective. So definitely a clinical implication, but it's not a comprehensive diagnostic approach. There's also newer molecular diagnostic tests, which are exceptionally sensitive and very specific. The turnaround time can be on the order of hours. And there's significantly improved sensitivity over blood culture, and has the added benefit of being able to detect antimicrobial resistance. The biggest limitations are they're quite costly. They do need specialized training, and there are infrastructure requirements to maintain the equipment. Metagenomic next-generation sequencing falls under kind of that category. It is a molecular diagnostic approach, but it's unbiased and it's hypothesis-free. And so the way that this works is you take a patient sample, whether that be blood or a nasal swab, and it goes through what we call a wet lab pipeline. So all nucleic acid is extracted. That's DNA and RNA, whether that's from the human, the host, or from the pathogen. It's all extracted and then prepared, processed, and tagged into a sequencing library. It then undergoes sequencing, and a sequencer can read millions of tiny fragments of DNA and RNA simultaneously. That raw data is then outputted to a bioinformatics pipeline, and we use the online open source CZID. There's a lot of pre-processing, quality control that goes on. There's removal of the human reads. And then the reads that remain are then aligned against reference databases to be able to identify all of the known organisms within that sample. Now, not every organism is a pathogen. So there's another very important step in which we apply a rules-based model to actually determine what we think the most likely pathogen is. And that's specific to both the sample and the patient. So metagenomic next-generation sequencing is highly sensitive for pathogen detection. It can detect bacteria, viruses, fungi, and parasites all simultaneously. It's a higher diagnostic yield than culture for all of those reasons. It's particularly valuable in culture-negative sepsis, immunocompromised hosts, and atypical infections. Or an advantage over the other kind of newer platforms is that it can identify new and unexpected pathogens. And it can also detect circulating bacterial genetic material even after antibiotic therapy. And like the other platforms, it can also detect antimicrobial resistance patterns. So we applied metagenomic next-generation sequencing to the same cohort of Tanzanian children with sepsis. And in this cohort, pre-hospital antibiotic administration was quite common. It occurred in 52% of children. And as I showed before, microbial blood culture identified a bloodstream infection in 5% of this cohort. So using metagenomic next-generation techniques, we were able to identify a likely bacterial bloodstream infection in 58% of children with culture-negative sepsis. That's a lot of bacterial infections that are being missed and potentially mistreated with the wrong antibiotic. Of course, there are limitations, and innovation certainly does not equate with access. So the major limitations are cost and infrastructure barriers. There's also the bioinformatics complexity and interpretation challenges. So how do you distinguish the signal from all of the noise? There are regulatory workflow issues, and then for resource-constrained settings, in particular, limited lab capacity and supply chain constraints. So unfortunately, adoption and access do lag behind innovation globally. And while metagenomic next-generation sequencing is not available in real time yet, through initiatives like this, it may be in the relatively near future. So this was a partnership between CZID, the BioHub, and the Bill and Melinda Gates Foundation. And they partnered with researchers in low and middle-income countries to get sequencers in country to better characterize the pathogen landscape. And so as the cost of sequencing drops and as our access to sequencing technology improves, it may be in the relatively near future that this is a real-time pathogen detection method. As we know, sepsis is an interplay between the host's immune response to an infection. And so there are pediatric specific challenges with this, right? There's immune maturity, which alters clinical presentation and response. So there's also likely a role for host gene expression or transcriptomics, and that could be in determining bacterial versus viral infections or for risk stratification. There's also this new emerging paradigm that there are treatable molecular traits. So a patient's inflammatory response actually influences their response to therapy. And so I think the next innovation is really going to move beyond pathogens in isolation and will integrate the patient's inflammatory response to infection. And so the direction is more in a point of care testing towards host signatures. So in summary, pathogen identification in pediatric sepsis, it remains a major challenge globally, and it's definitely exacerbated by the global diagnostic gap. Our traditional culture-based diagnostics, our current gold standard, are actually slow and insensitive. We need to advance beyond that. Metagenomic next-generation sequencing and molecular tools are potentially transformative, but they're not yet universally accessible. And the future lies in making diagnostics equitable and available, and ones that take into consideration both the patient and the pathogen. There's a lot of people to thank, and I also want to thank you for your attention, and happy to take questions.
Thank you very much. I totally agree with the the direction of rapid diagnostics compared to the culture-based approach. Having said that, how do we apply that in a low middle income setting, and is there a practical way that this can be kind of implemented in such settings?
I think through partnerships like I described, being able to get the sequencers in country and then being able to upload the data to a open source cloud-based pipeline, which is currently available, is a way in which we can kind of pool our resources and be able to extend the technology. I do think I think in many places still microbial culture is not a standard of care, is not available. And I don't know that we necessarily have to have extensive microbiological labs everywhere. It may be that this is a situation in which we can leapfrog in terms of technology, just like we skipped over landlines in many places and went straight to cellular phones. Maybe we don't need to have the core microbiology labs in order to be able to do some of these more complicated molecular diagnostics. And I think the other thing is cost, right? Cost really determines accessibility. And so this is where global priorities and determining where we invest our resources and money are going to be key. And we can all help advocate for that.
What about something in the middle? So using qPCR, based on knowing the pathogens profile for each country. I think that would also help with implementation, maybe because metagenomics is not, next generation sequencing is not just expensive, but it also requires way more skill set that may or may not be available.
Yeah, I think you're right. I think right now its greatest power is in being able to define the epidemiology of infection in a particular area. So if we can at least have an idea of, from a surveillance perspective, of what the likely pathogens are, we may be able to develop our empiric therapies better. And certainly, yeah, something in between absolutely could be transformative as well.
Perfect. Thank you very much, and for again another great presentations. And I hope we the people that are listening could also try to think about practical ways to implement this in their own settings. So moving forward, it is my pleasure to introduce the next speaker, Dr. Brenda Morrow, who's a full professor in the Department of Pediatrics and Child Health at the University of Cape Town, South Africa. And she has special interest in interdisciplinary pediatric critical care practice and research, global health, cardiopulmonary rehabilitation, palliative care, and medical ethics. Brenda, the floor is yours.
Thank you so much for the invitation to present here amidst these really incredible colleagues. So I'm talking about the challenges in post-discharge management of pediatric sepsis survivors. And my background and experience is really in resource-limited settings, where there are the most challenges with patient follow-up, I think. And so this is the context that I'm going to focus on in my talk. I want you to consider maybe a 2-year-old who survived sepsis and 10 days of organ support in a high dependency unit. The child improved and was sent home with a discharge letter, and then she was never seen again. No follow-up appointment was made, there was no nutritional review, and she died at home 6 weeks later from a recurrent completely preventable infection. Or maybe another child, this one a 7-year-old who was previously well, attending grade 1, who was discharged home after 3 weeks hospitalization with septic shock in the context of a resource-limited hospital where there was a huge demand on beds. In this case, the mother was given a letter to the community health worker, but no name was given or contact details for that health worker, and there was no formal follow-up arranged. 1 year later, this child is not going to school anymore because the teacher said they couldn't cope with the work anymore. Or maybe the child was not physically able to walk the 2 kilometers to school every day. It's these children that are the focus of this talk, really highlighting that hospital survival should not be seen as an endpoint in itself. We also need to focus on what comes after discharge. This slide comes from Matthew Wines and others' work in Uganda, specifically in resource-poor settings. We know that children who survive the acute sepsis period are at substantial ongoing risk of mortality after discharge. So in this Ugandan study, nearly 1 in 18 children who left hospital alive after sepsis did not survive to 6 months. And the median time to death was just 32 days, with most of those children dying within 1 month of going home, mainly from recurrent infection. But I think the most striking figure is that about half of all sepsis-related deaths occurred after discharge, and 2/3 of those dying actually died in the home rather than in healthcare facilities. And results from several other studies from low resource settings are very similar. So hospital discharge is clearly not the end of the risk period. It's actually the beginning of a largely neglected period where there's continued or even increased risk of mortality. And I think the fact that most post-discharge deaths do not occur in a facility suggests that appropriate health seeking and access to care at both the individual and the health system levels are important barriers during that post-discharge period. Beyond mortality, survivors of sepsis are also left with substantial morbidity, including physical, neurocognitive, and psychosocial and cognitive impairments. Studies from both high and low income settings have shown us that up to 1/3 of sepsis survivors from all resource contexts are left with mild to moderate and even severe disabilities and poor functional outcomes after their acute illness. In low and middle income populations, underlying malnutrition and immune vulnerability compound this risk. Post-sepsis immune dysregulation also increases susceptibility to reinfection, and all of these sequelae have a profound effect on quality of life for the child and for their family. Within this context, we need to acknowledge the low and middle income country, the so-called data gap, which is well described, because most functional outcome data come from high income settings. We have developing evidence for mortality after discharge, but we don't know nearly as much about functional outcomes. And we need to be careful about simply extrapolating those data from high income settings where populations have fundamentally different baselines, including nutritional status, comorbidities, and the health system context. We also cannot underestimate the burden of these post-sepsis sequelae to the caregiver and the family. The post-discharge care and follow-up imposes a substantial physical, emotional, and financial burden to both the caregivers and the family of these children. So why is post-discharge management so challenging in low and middle-income settings? So firstly, we need to look at fragmented health systems. I think there is a very large structural and process gap between hospitals and community facilities and the home. The hospital team often has absolutely no formal links or methods to communicate with community health workers or district facilities. There are generally no shared health records or electronic referral systems in my experience. The other thing that's interesting is that most community-based health workers in settings that I'm familiar with are very well trained to prevent sepsis and to identify red flags for acute illness and to up-refer, but they may not be as equipped to deal with down referrals after acute illnesses. So the child is essentially discharged into a void. Within that void, there are substantial workforce gaps as well. There's very limited and often absolutely no pediatric rehabilitation services at district level in most low-income settings. And even where rehabilitation resources exist in tertiary centers, follow-up capacity is then overwhelmed by the acute demand. Having rehabilitation services available in the centers means that the families most in need of follow-up, the children living in rural settings, the severely ill children, the most impoverished children, are least able to travel back for the care they need because of geographical and financial access barriers. And this is really a structural injustice as well as a logistical challenge. We also need to acknowledge diagnostic invisibility, because subtle cognitive and functional consequences are often invisible without systematic screening. A quiet or a slow child post-sepsis is unlikely to trigger concerns unless clinicians and caregivers are specifically looking for the signs. I have heard parents say that they're just grateful their child is alive and they wouldn't want to complain, for example, for something as small as the fact that their child is no longer able to attend school. And then there are a number of social and cultural dimensions. There are varying social and cultural frameworks and belief structures around illness and recovery. In some settings, there may be stigma associated with both the illness and the healthcare sought and received. And in the context of multiple household demands and stresses, follow-up may not be prioritized. So what are some practical frameworks for post-discharge follow-up? So smart discharges is a concept that has been described, and Nelson referred to this in his talk earlier, where smart discharges aim to specifically direct limited resources towards the children most at risk of poor outcomes. So we need to identify and target those children. For example, targeting children for active follow-up who've had specifically prolonged hospital stays. Those with more severe organ dysfunction, for example, with higher Phoenix scores, with severe malnutrition, neurological involvement, or where there's very high social vulnerability. Developing a structured discharge bundle appropriate to the context would definitely improve the quality and standardization of post-discharge care. And this could include simple interventions like a written caregiver summary in the local language with a lay description of warning signs for the caregiver specifically. Nutritional assessments on discharge with targeted supplementation, specific vaccination reviews. We know that many survivors are behind on their immunizations. And we need to provide a very specific and named first follow-up contact with details on how parents can actually contact those people. From education and community integration, rather than trying to build parallel systems, we could try to link with what already exists and works. In many low-income settings, immunization programs and infant growth monitoring clinics are very well established. So we could use those structures and facilities and incorporate post-sepsis care and screening into those structures. And we need to be actively training our community health workers and our caregivers to screen for red flags of recurrent infection and for developmental and functional concerns. We need to focus on the family with specific education rather than generic advice, including, as I said, explicit warning signs and giving them realistic recovery expectations. We can also support families by providing them rapid access to hospitals and clinical consultation in the event of their concern for recurrent infection or other functional concerns. We could consider models of waiving costs for readmission, which also may be a deterrent to health seeking in these contexts. And there are a number of low-cost screening tools that can be easily taught and used across the health system for evaluating neurodevelopment and functional abilities. For example, the functional status scale, the POPC. There's a Malawian tool that's been developed in that context as well. They require no equipment and can be administered by a number of different individuals. From the research and advocacy perspective, we cannot pool data, compare interventions, or build evidence without agreed definitions for outcomes. And so we do need standardized consensus on core post-discharge outcome measures relevant to resource variable contexts. Again, we could try and embed post-discharge follow-up into existing research platforms using existing infrastructure. We know that post-sepsis care is absent from most regional or national child health policies and essential service packages, and that gap can be closed with advocacy from this audience. We also need to look at the economics, because prevention of readmission and of disability is likely to reduce costs within resource-constrained settings. And I think that economic argument needs to be made explicitly to health ministries and policymakers as well. So Teresa has mentioned some of this work. And so I just want to highlight that there is action, I'm pleased to say. There is consideration of the vital role of post-sepsis care in the sepsis chain of survival and in very recent guidelines that Teresa led for improving sepsis, pediatric sepsis care and adult sepsis care and outcomes across all healthcare contexts, from the home to the healthcare facility and back again into the community. And as a number of speakers have also said, for the first time, long-term follow-up and rehabilitation have been included in the surviving sepsis guidelines with a good practice statement that despite a lack of high-level scientific evidence, post-discharge care should be implemented, including risk stratification at discharge, family and clinician education on post-sepsis symptoms, and evaluation for new morbidities after discharge. So in conclusion, I think we've spent decades working out how to keep children with sepsis alive in the hospital, and that work obviously matters enormously. But if we send these children home without a plan, without a referral, a contact, without screening, we're only completing half our job. Hospital survival without recovery is simply not good enough. We have to be changing our thinking. We have to see hospital survival as the start line to the child's future health, focusing on safely integrating the child back into their family, their communities, their schools, their life. And I believe it is our duty to extend our responsibility to what happens after discharge. Because, to quote this wonderful article by Hartman and Lynn, what a tremendous accomplishment it'll be when a good save means a child that is not just alive, but also fully living life. I thank you for your attention.
Thank you very much, Brenda. And you know, this actually brings a very important topic, which is patient and family empowerment, and you know, and the concept of co-production. So even upstream, if we want to go to, you know, community-acquired infection and how we can empower the community with the, you know, with the right message so they can come in early. And they you know, we've seen patients even are being discharged from the emergency department, even though that they had, you know, signs and symptoms of sepsis. Can you speak to that, you know, topic from the very beginning all the way, you know, through the hospitalization and afterwards? Because I think, especially in low middle income setting, but I would argue in any setting, and unfortunately, we as healthcare providers need to do more in terms of co-production and empowering, you know, patients and families.
Absolutely, and I think the work that Teresa led, that I was lucky enough to be involved in, with regards to the 10 steps for improving sepsis outcomes, speaks specifically to that. So it moves from the community, the household, the home. And it's what can we do to prevent sepsis within the home setting, within the community setting, within the school setting. How can we empower and educate caregivers to recognize the early signs and of sepsis? And then what can they do about it? Who can they flag that to? What is the pathway to care from then? And is that pathway actually established in a meaningful way? So moving from the home into the facility, is the communication in place? Is emergency transfer facilities, are they in place? Do the EMT practitioners know what to do and how to recognize and how to action? And then moving to the facilities and the management, which I think there's been a lot of focus on that acute management. But I think what a lot of what is missing is afterwards. So it's from that discharge, because everybody's so relieved the child has survived, that it's almost that you breathe a sigh of relief and think your job is done and step away. And oftentimes people working in acute facilities are completely unaware of what happens afterwards, because we don't follow those children up. At the very least, what we have a responsibility to make sure that the child is being followed up. And it doesn't matter who that's by, really, because by training and empowering people throughout that chain of survival on a down referral basis, we can make sure that any red flags are picked up, that the child does get screening, that they get nutritional follow-up, that they have growth monitoring, vaccination, and, as I say, very, very simple functional developmental screens that can make sure that they are kept on track. And from the central facilities, we can teach parents how to provide basic rehabilitation and neurodevelopmental support, and that's some of the work that we do in our setting. Rather than treating them in the facility, we want to empower the parents to be able to provide rehabilitation in the home. So it's a complex, and I'm trying to answer very quickly, but there's a lot of exciting work that could be done here.
No, and again, it's the continuity of care, the whole care continuum. We think as healthcare providers that everything revolves around the acute care setting, but I think if we look at it from a citizen person care, I think that changes everything. So I hope that also people listening will take that to their own practice. Even an uneducated parents can be very much empowered by the right kind of message and the symptoms and signs to look for, so they can actually help us help their kids.
Absolutely.
Great. Well, thank you very much. And I keep my eye on the iPhone just to kind of keep a track of our audience, and they have continued with us. So I'm sure that because of the great topics that you guys presented. So now we move to the last presentation, and it's my privilege to introduce Dr. Natalie Schellack, who's a registered pharmacist, professor, and currently the head of the Department of Pharmacology at the University of Pretoria. She holds 3 degrees, 2 bachelor degrees in nursing and pharmacy, and a PhD in pharmacy. So Natalie, the floor is yours.
Thank you so much, and I'm so privileged to follow great speakers. If I can just confirm if you can see my slides and if all is well.
We can see your slides.
Okay, great. Thank you. It's now, completely dark in South Africa, as you can see. But yes, thank you very much to the Global Sepsis Alliance for allowing me to talk. And I'm very privileged to follow on to my colleagues. And today I'll be talking about the provision of appropriate, timely, and safe antimicrobials for pediatrics across South Africa. And then, yes, just to move on to this topic. My declaration is, I always say, this is my daughter, and she's never excited to see this on a slide. But just to say always that I don't have any declaration of interest, but children are really different. But we can never say that they are Martians. We know that they've got their own pharmacokinetics and pharmacodynamics, but definitely not Martians. So just to talk about, this is a great publication that I've seen. I know many of you have seen, and it's mentioned that this is a Lancet analysis done by Ruud and colleagues, and it gives us a really comprehensive picture around 195 countries from 1990 to 2070. And in 2017, they've estimated that around 48.9 million sepsis cases and 11 million sepsis-related deaths worldwide. So that's around 1 in every 5 people on the planet, that's been admitted has been involved with sepsis. And then more than half of these patients is in children and in adolescents. So that gives us around 20 million sepsis cases and nearly 3 million deaths in children. So you can see South Africa and Africa, where I'm located in Pretoria, so around there, we are really affected by sepsis, and all of the conditions that it brings about. So when we talk about AMR in children, there's a study published and released last year at ESMID, and we can see that 3 million children worldwide died from infections caused by antimicrobial resistant pathogens. And for us in Southern African, South Africa, you can see really, when we talk about this, it's about 160%, and then more or less 126% that is linked directly to watch and reserve category antibiotics. And this makes us really worried, because these are almost like our workhorses, like our cephalosporins, our quinolones, our carbapenems, that we are really seeing in Southern African Saharan that we are becoming resistant to. So for us, it highlights surveillance and really the prioritization for really targeting antibiotics for well-defined indications. So it means that we have to reserve our antibiotics for really well-defined indications. And when we talk about access antibiotics, more than 60% of the antibiotics that we are using is access antibiotics, but they fall within the cephalosporin class. So, for example, cephalosporin, ceftriaxone, cefotaxime, ceftazidime. And we know that resistance normally follows like a faithful shadow, like Fleming said. So as we move on, you can see that this global study that was done, if you look at section B, younger than 5 years, if you look at this is really a systematic analysis. It was published in the Lancet, and you can see that in South Africa and sub-Saharan Africa, when we look at the intersection around neonatal sepsis, we can see that there's really an increase in gram-negative pathogens, and you can see especially Escherichia coli, Klebsiella pneumoniae, and luckily for us, Streptococcus pneumoniae, which is really reduced, and this is because of vaccination and IPC practices. But for children above the age of 5 years, we have seen an increase in gram-negative pathogens. So when we look at the new pediatric sepsis guidelines, has been touched on by my colleagues previously, we can see now that's really, I would say, almost welcoming, is that it's no longer so binary. So in other words, they've combined the Phoenix criteria for sepsis, plus they combine life-threatening organ dysfunction. So now we were almost rushing to get this antibiotic up to, within an hour. But what they've shown us is that when you look at septic shock, it combines sepsis plus cardiovascular dysfunction. So we have to look at all of these cases. So many children fall into this almost probable sepsis with a diagnostic uncertainty, and with the capability that we have in South Africa regarding, and many places like South Africa where we don't always have biosurveillance, we have to really apply clinical surveillance. So when we talk about sepsis and almost diagnosing sepsis, what are we talking about? Is it timely? So in other words, are we treating sepsis? We all know the Kumar and Clark study, right? So for children with suspected septic shock, the message is pretty clear. Start antimicrobials as soon as possible. So similar to Kumar and Clark, 1 hour within recognizing sepsis. But without shock, the panel recommends a time limited but almost a meaningful diagnostic window. So where we look at 3 hours if the concern is substantiated. So there's almost a move away from this rigid clock system towards recognizing different priorities. So for children with suspected septic shock, we can now look at these classifications. We've got suspected septic shock, probable septic shock, and there's some newer nuance. So not every febrile child needs an antibiotic within 60 minutes. So when we look at this study that was done by Lane et al. In 2024, you know, we've talked about this pediatric inflection point. So in other words, when is this magic window? So we have this bacteremia subgroup. So in other words, where we've got the inflection point for time to antibiotics at 90 minutes. So in other words, there's this slope that you can see on this study that was published 2 years ago. So children that has got a bacteremic origin are likely to benefit from timely antibiotics. But in South Africa and Sub-Saharan Africa, many of these septic cases are caused by drug-resistant TB. So when they looked at this whole cohort, they've seen that within 330 minutes, you know, so it's not an hour, you've got a little bit more time, you've got about 3 hours, you can move and provide antibiotics. So very early antibiotics, less than 30 minutes, interestingly enough. So if, for example, many of the malignancy protocols or neurogenic protocols, there was a higher mortality when we started the antibiotics too soon. So that was also very, very interesting from this study. So always I like to teach my students, we have the mug, the bug, and the drug. So when it comes to sepsis in children, the mug is really the child in front of you. So in other words, what are all the risks? So in other words, are they immune compromised? Are they multi-drug resistant? Do they already have those phenotypic expressions? And in South Africa, we've seen some of the bugs, so we know more or less what we are dealing with. So for the audience today, I would like to ask you, what are your bugs? So what are you treating empirically? You know, we can have all of these guidelines, but you really need to know what your biograms are. And then drugs is the empiric regimen, and that's what I'm talking about today. So we've got this access versus excess problem in South Africa. So do we have access? We've got access, but many times we almost have excess. So we almost use too much of the access drugs. So what I found very interesting in the new guidelines, the Surviving Sepsis Guidelines of 2026, they still talk about a broad spectrum therapy to cover the most likely pathogens. And then in immune compromised children, they still suggest empiric multi-drug resist, therapy. So that would most likely be an aminoglycoside plus a penicillin. And they still talk about undertreatment of multi-drug resistant sepsis, and where we have almost this indiscriminate multi-spectrum in all children. So we really need to know our timing, our origin, and the drug. So we really need to know what is our mug. In other words, where is our child in terms of the sepsis progression? That's a nuance that I've included. What is our bug? So what are we treating for your specific setting? If whether or not you are in the States or in this, Australia or Europe or South Africa, what is your bug? What is your biogram? And what drug are you going to use? And there has been some great talk around the PK/PD of the beta-lactams. Should we use it as a continuous extended infusion over intermittent dosing? And there still isn't convincing data to say that we should have continuous infusions of the beta-lactams in children. So just a small point around ethics in AMS. So we still talk about, you must remember if you provide an antibiotic, there can be side effects and effects. So if you provide an antibiotic where there is no effect, you are just providing side effects. So if we talk about this principle of utilitarianism, so that's almost like a consequentialist theory where we look at the morality. So in other words, where we've got this precious resource and are we using it correctly in our setting? So there's an ethical almost preamble. So access versus excess. So many of the newer drugs, I don't know where you are based, where you are listening to from tonight, but in South Africa, we are reminded that we have the same sort of pattern that what we've seen in COVID, where we see the same pediatric antibiotics and the formulations. And oftentimes in many of our settings, we have to use antibiotics that we've got benevolence. So in other words, we are using this antibiotics for our setting, but oftentimes we know we are using it when there really is no hope. So, for example, if we look at prioritarianism, is we treat the worst of. So there's a large discussion around palliative care of using antibiotics. But in most instances, we have really good access to first-line antibiotics. So those are access antibiotics. But children with multi-drug resistant infections often sit in public sector hospitals where the newer drugs, almost like the reserve antibiotics, are only given to them under a specific section 21. And you all know that into this, we only have a certain limited time. So we've got access. So yes, we've got access to access antibiotics, but we need reserve antibiotics. The time delay can often be really not beneficial. So there has been some discussion around some of the key findings, and I just want to say that there is a caveat. When you look at some of these studies and where it's grouped, so we know that for neonates, it's mostly gram-negative pathogens in low middle income countries, but we do see Staph aureus, including MRSA, in children that's older than neonates. But I just want to remind the audience that many of these studies are fragmented. So in other words, where you get some of the data, the mortality surveillance, remember that it comes from different labs. So there's heterogeneity by region, by age, and healthcare setting. So we really need to find a standard way of almost, providing the data so that we can move forward in a way that we can use this data globally. So what's happening in Africa, and there's been many discussions. So if you look at this slide, it's really a great slide, but it talks about, African children are really hit a little bit harder because there's socioeconomic drivers, there's overcrowding, there's poverty, there's weak primary care. And primary care is really important because you can prevent many of the multi-drug resistance if you can treat them at the primary care. And a lot of it links to WASH. So in other words, basic water, sanitation, and hygiene can really change the scale for neonatal sepsis. Okay, so from global priorities to local actions, I've spoken about WASH. Another aspect that we really need to talk about is developing low-cost diagnostic settings for resource-limited settings. So in other words, we can really see what we are dealing with quickly. And I really like the discussion around metagenomics. So then, and thirdly, is using smart antibiotic use across human and animal health. We've got a great agricultural setting in South Africa, but we need to explore how we are using the antibiotics because eventually that will filter into neonatal opportunities. A great study is a neonatal AME study. It was the first national study in South Africa. It was done over about 5 months, so that's 20 weeks, pharmacist-led. And where there was really a very defined focus on antibiotic use, it was interesting that culture-negative sepsis was actually one of the most important intervention sites for the pharmacists to change antibiotic use. I just want to spend 5 minutes around vaccines. During COVID, I don't know about many of the countries, but South Africa really took a hit in facing vaccination, and this has a major implication for sepsis, because what we found is that's really a reduction in diphtheria, tetanus, and pertussis vaccine. It's dropped to 76%, and measles, it's the lowest since 2006. And we've unfortunately, even if you look at some of this unpublished data, South Africa is at its lowest point when it comes to immunization, and I'm really concerned about this. Polio vaccine, we nearly lost our, our status for polio vaccination. It's dropped below 50%. We just made it to be marked safe, but this will have a direct implication when it comes to sepsis. And it's been identified in many publications that we really need to improve the vaccination for children. And we all know that, vaccination has got a direct effect to antimicrobial resistance. So it's one of the most important strategies for us. If we can, at any point in discussions with patients, just really have a discussion around vaccination. It's reduced killers like pneumonia, diarrhea, and measles. So that really is a quick win for us when it comes to vaccination and antimicrobials. And there's been some promises when it comes to new discoveries for bacterial vaccines, with 94 active preclinical vaccine candidates and 61 active developments in vaccine candidates. So you can almost see what has been licensed. Look at the Streptococcus pneumonia, which has been really plaguing sub-Saharan Africa. So, at every point when you can speak to a patient, just talk to them around vaccination. And what works? In South Africa, AMS bundles works. Point of care tests work. Audit and feedback works. But it's important to provide education as well. And then more recently, we've also seen substandard and falsified antibiotics within sub-Saharan Africa. So it's very difficult to say what the dates are, what the numbers are. But if you look at this figure, if you have a substandard or falsified antibiotic, it really reduces the percentage of API, and that can increase the resistance factors. So there's a really great test that you can use to test if your APIs is functioning, and that's also something that we are investigating in South Africa. Over-the-counter use of antibiotics, a major challenge still, and unfortunately this will have downstream effects for neonatal sepsis if our population is exposed, and this is rife throughout South Africa. So in other words, this study was done just this year, and that 90% of public agreed that overusing antibiotics will lead to resistance, but still does it because of the economic factor. And we still see penicillin as one of the most frequently used over-the-counter antibiotic. And I'm just mentioning this because it's the first line antibiotic used in neonates as well. Last year, I just want to finish by zooming out. Antimicrobial resistance is not just a sepsis problem. It's a countrywide problem. So from empiric use to use in children. But there was a G20 meeting last year in Sub-Saharan Africa, and they've really committed towards some of the WASH principles, so infectious diseases, and then really talking about looking at how we respond to antimicrobial resistance. And this includes surveillance, understanding the existing antimicrobial resistant landscape. So it needs to be evidence-based and data-driven, and because we are a very large paper-based system in South Africa, we have to rely on I would almost say tender-based data. I'm not sure how that translates. So in other words, procurement data. But in the public sector, for example, you can see a lot of it is still driven by HIV. So where you are staying, you might see, if you look at that, trimethoprim, that's Bactrim. It might be used in your setting for UTIs. In South Africa, it's still used for HIV conditions or pre-exposure. And even in the private sector, which is about 14%. So maybe just to end it off, Chair, just to say that when it comes to pediatrics in South Africa, you can still see that in this point prevalence study, the majority across 18 settings, you can see that it's still largely driven, luckily, by watch antibiotics and I would say access antibiotics mostly, depending on the setting. And then when a patient is admitted in a hospital, then it becomes a reserve antibiotic. But what the data still doesn't tell us is what drives this change. Is it behavioral because we've got many different languages in South Africa? Is it cultural? Are we really targeting it as we should? And are we informing the public as we should? So final thoughts, I would say that AMR remains a major threat to children worldwide. We do have many wins like vaccines. And in Africa, we still need to think about digital innovation and some basic thoughts around washing and, washing hands. And thank you very much for the opportunity to present tonight. Thank you, Chair.
Thank you very much, Natalie. So let me ask you this. The balance between antimicrobial stewardship and antimicrobial resistance. And, I've heard from many physicians, especially in the emergency department, that sometimes the poor understanding of antimicrobial stewardship policy results in delayed access to, antibiotics. How can you, address both issues?
Yes, it's a challenge because it depends on where you are being treated. So if you are treated at a community setting, you won't have access to reserve antibiotics. So it depends on the level of care. So we've got access to many of the antibiotics, but it depends on your level of care and it depends on access to healthcare system. So we have the antibiotics, but it's access to the healthcare setting where you are currently at. And I think that really still drives our mortality in children under 5. So if we can remedy access to healthcare settings, it would change the patterns that we are currently seeing.
Great. Well, thank you very much. And that concludes our session. So I just want to go back and give you a summary of what we discussed. We talked about the technology impact on pediatric sepsis and, things like prediction and early diagnosis. We also had some practical conversations about, fluid resuscitation and the use of inotropes and when and how. We also have had, discussions around the infrastructure impact on sepsis diagnosis and treatment in low middle income countries. We talked about the pathogens, and I remember this percentage, 59% in one of the studies showed that 59% of the culture negative sepsis, so clinically they had sepsis, but then they had negative cultures, and also had a good discussion around the rapid diagnostics and how can they be implemented not just in high income setting, but in low and middle income setting. Again, a great conversation about post-discharge mortality and the importance of patient and family empowerment. And finally, the last presentation, we talked about the WASH principles, some basic principles of infection prevention and control, as well as the important topic of antimicrobial stewardship and AMR. So at the end, I would like to thank our distinguished speakers for their valuable insights, and to our global audience for your engagement. You've been with us for the past almost hour and 45 minutes. Today's discussion highlights that while pediatric sepsis remains a serious challenge, it is also an area where innovation and collaboration can truly save lives. My sincere thanks to the organizing committee of the World Sepsis Congress and to our sponsors for making this important session possible. Thank you all, and let's continue working together to improve outcomes for children everywhere.
Thank you, Chair and colleagues.